Coleman Supportive Oncology Initiative, Distress Training Module, The Impact of Distress on Patient Care, Dr. Frank Pinedo. By the end of this module, you should be able to define stress, distress, and depression, identify sources of distress and why it warrants screening, and explain the impact of distress on cancer treatment and quality of life, and how to treat distress in cancer patients. The NCI and professionals have defined stress, distress, and depression. Stress can be defined as the body's response to physical, mental, or emotional pressure. Stress can cause chemical changes in the body that can raise blood pressure, heart rate, and blood sugar levels. It can also lead to feelings of frustration, anxiety, anger, or depression. Stress can be caused by normal life events or by an event such as trauma or illness. Long-term chronic stress or high levels of stress that persist over time can lead to mental and physical health problems. The term distress is defined as the emotional, social, spiritual, or physical pain or suffering that may cause a person to feel sad, afraid, depressed, anxious, or lonely, among other emotions. People with distress may also feel that they are not able to manage or cope with changes caused by normal life activities or by having been diagnosed and treated for a disease such as cancer. Cancer patients may have trouble coping with their diagnosis, physical symptoms, or treatment. In contrast, depression is defined as a mental condition that is marked by ongoing feelings of sadness, despair, loss of energy, and difficulty dealing with normal life. Other symptoms of depression can include feelings of worthlessness and hopelessness, loss of pleasure in activities, changes in eating or sleeping habits, and thoughts of death and suicide. Depression can affect anyone, but it can also be successfully treated. Clinically elevated depression affects about 15 to 25% of cancer patients versus about 7% of the U.S. population, that is age 18 or older, in a given year. Standards and guidelines for distress screening and treatment. Given the implications for adjustment, adherence, and outcomes, the Commission on Cancer and other national bodies now call for routine distress screening for cancer patients. Screening patients for distress and psychological health needs has been conceptualized as a critical first step to providing high-quality cancer care. It is therefore expected that distress should be recognized, monitored, and documented, and treated promptly at all stages of the disease. All patients with cancer need to be referred for the appropriate provision of care, high-quality psychosocial cancer care that includes a systematic follow-up and reevaluation across the cancer continuum. Sources of distress. Fear, uncertainty, and stigma about cancer can all lead to distress. Cancer can be a frightening experience for many patients, their families, and caregivers. They can feel hopeless about the disease, they can be anxious about possible outcomes, and they can be concerned about support systems that individuals around them do not quite understand. Patients may experience distress as a result of disease monitoring, treatment-related side effects, uncertainty about the future, financial burden associated with their care, and physical limitations associated with cancer and treatment-related impairment. Cancer itself remains a stigmatized condition, particularly for some specific racial and ethnic minorities. Among survivors, even those with a good prognosis still fear cancer recurrence. There are biological sources of distress as well. Pain and distress can create a negative spiral. In advanced disease, pain may contribute to a desire for haste and death. Cancer treatments and stress can exacerbate symptom burden via their effects on the endocrine and immune systems, inflammation, and central nervous system physiology known to regulate mood. How common is distress? Distress is very common, but it ranges in severity. 25 to 33% of cancer patients are distressed versus about 7% of the general population. Stress associated with cancer and its treatment may trigger clinical levels of distress, such as major depression, which is marked by depressed mood, hopelessness, and anhedonia. In other conditions, such as post-traumatic stress disorder, distress can be marked by relieving a trauma, avoidance of a specific situation, and increased arousal. Cancer itself may exacerbate pre-existing anxiety, depression, and trauma. Patient stress may be kindled by past experiences and also exacerbated by cancer. Stress reactions. Stress is a normative response when life and resources and values are threatened. Stress is experienced when the demands placed by a stressor, such as a negative life event like a cancer diagnosis, outweigh the patient's resources to cope with that event. Cancer is viewed as a chronic stressor that threatens life, resources, and values and leads to distress. Since cancer is a long-term chronic stressor, it demands ongoing access to coping resources and psychosocial services, such as social support, counseling, information provision, and relaxation strategies. Most cancer patients experience some distress at some point during their care. Diagnosis, treatment, and disease progression points are commonly the most distressing periods for cancer patients. The patient's background, their experiences, and their value systems can impact how they respond to stress and experience distress states. Shock, disbelief, anger, and sadness are typically common. While most patients adjust relatively well, patients with premorbid mental health conditions, a history of depression and anxiety, poor coping resources, advanced disease, and poor prognosis experience the most distress. Distress impact and the need to screen for distress. Distress, along with chronic stress, can negatively impact health outcomes via its effect on physiological mechanisms such as immune function. Distress can impact a patient's medical decisions and adherence to treatment. Cancer can be frightening to patients and their family, and rates of suicide are doubled among patients with cancer. Cancer can also be painful and reduce many aspects of quality of life, including social, emotional, and physical functioning, which may cause further distress. However, distress can be effectively treated by understanding, empathizing, and providing necessary referrals to psychosocial services. Stress's impact on health outcomes. A meta-analysis of 76 studies found that depression is associated with mortality across disease types. Additionally, stress and related processes can lead to immune dysregulation and trigger inflammation. For example, stress has been linked to impaired natural killer cell cytotoxicity among patients following breast surgery and in prostate cancer patients. Stress has also been linked to poorer recovery of blood counts following stem cell transplant, and it has been related to greater risk of disease progression. Additionally, having cancer is associated with a twofold risk in suicide. Patients may be simultaneously fighting for their lives and contemplating ending their lives. Risk factors for suicidality among cancer patients include being older, being a male, being unmarried, having advanced disease, and having lung, stomach, or head and neck cancer. Distress impact on communication and decision making. Mental health concerns are not often identified in medical settings. Patients may be too scared to ask for help. Providers may worry that asking about their stress will only make it worse, and providers may have limited resources to refer patients to address their necessary needs. Shock, worry, and anxiety make communication more difficult. Patients may be too overwhelmed to concentrate. Patients also may be too irritable and may push away others. Stress can impact also a patient's decision-making process. Depression triples the risk of general medical non-adherence. Patients weigh emotions and well-being heavily when making decisions. Some patients believe that treatments will not work. Some patients overestimate the negative impact of the side effects. Patients also facing stress may learn to avoid upsetting places or situations that trigger fight or flight stress responses, which cause them to avoid treatment follow-up and compliance. Furthermore, lack of energy or poor concentration associated with stress can make it more difficult for patients to make and remember appointments, to plan for the future, and eventually comply with the necessary treatments. Treating distress. Good patient-provider communication may be the first intervention. Non-pharmacological therapies such as cognitive behavioral therapy and relaxation techniques have proven to be effective. These techniques usually involve provision of problem-solving skills, coping skills, and communication skills, optimizing efficacious social networks available to the patient, providing psychoeducation, understanding stress responses and their link to behavior and emotions, and relaxation strategies such as deep breathing and mindfulness-based meditation. Psychopharmacological treatments have also been effective, such as provision of SSRIs like sertraline, citalopram, and escitalopram. Summary of points covered. In this module we address that cancer can be a stressful experience. We also discussed that patients may internalize their emotions, shut down, push others away, and avoid what they need the most, and as a result patients may feel less supported than they could be. We also learned that not effectively addressing their psychological, practical, and physical concerns can compromise adjustment, compliance to treatment, and health outcomes. And finally, we know that effective treatments are available, but intervention begins with assessing and addressing symptoms on a routine basis.